So our next presenter is Genevieve Dingle. She's a registered clinical psychologist and an associate professor at the School of Psychology at the University of Queensland. Her research examines how groups and communities can influence mental health and well-being. This includes both formal groups such as cognitive behavioural therapy groups and therapeutic communities for alcohol and other drug treatment, as well as arts-based groups such as choirs and creative writing classes. She's leading an ARC linkage grant-funded project evaluating social prescribing as an approach to managing loneliness. So Genevieve and her colleagues have summarised their work in a 2018 book, The New Psychology of Health, Unlocking the Social Cure, published by Routledge, and we can provide the full title of that in the resources in the next couple of days. Genevieve, I'll hand it over to you.
Okay, wonderful. Thank you so much for having me. Hopefully you can see that on your screen. I wanted to say fairly early on that I'm not a pain specialist. I'm a clinical psychologist, and my background is more looking at loneliness or social connectedness and health. And I also have an addiction research background. But a lot of the stuff that I've been working on has got direct relevance to the population that you've been talking about tonight. I certainly wouldn't want to undervalue or take anything away from the important biomedical and psychological approaches to managing chronic pain, all of which are obviously well evidence-based, etc. But I find that within this biopsychosocial model, often we're kind of paying lip service to the social aspects. And so that's the bit that I'd like to really probably pay a bit more attention to in my talk here tonight. Yes, I'm going to really focus on the idea of loneliness and why it's important for us to pay attention to. If anyone would like to ask me a question after tonight or something occurs to you later, the best way to contact me is the email at the bottom of the slide there. Okay, so why are we talking about loneliness? It's become very clear in the last probably 10 years or so that loneliness, even though it's not a diagnosis as such, it's not an actual disorder, but it's a transdiagnostic risk factor for a whole range of health and mental health issues and even life expectancy. So I'll give you a flavour for some of that research here on the slide. So Holt-Lundstadt's, this is a big systematic review where she found that the effect of loneliness on mortality was equivalent to smoking 15 cigarettes a day and was actually more impact than things like obesity and lack of exercise. So it was really putting those social factors up there against some of those much more well-established health behaviours that we know about. Loneliness is also, sort of related to 15% increased risk of depression, increased risk of suicidal ideation and behaviour, 30% increased risk of stroke, a whopping 64% increased risk of dementia. We know from my own colleagues at UQ that when you look at, if you do an audit of your GP practice of the, say, 10% most frequent attenders amongst your patients, you will find that they will have a much higher scores on measures of loneliness. And that's when you've already accounted for factors to do with their actual health conditions. And we know that also amongst older adults, loneliness is associated with increased risks of readmission to hospital after they've been treated for something and sent back home, and also longer stays within the hospital. So looking at this across a whole broad spectrum of different kinds of health indicators, we know that loneliness is a really quite a serious issue that needs to be assessed and then addressed in a timely way. When we look at it in the context of pain, which of course is the topic for tonight's panel, this is not my area of interest, but I have been able to find a couple of key pieces of this puzzle. So this paper here is not even actually published yet, but ahead of time from the November 2020 issue. This was a massive study from the UK Biobank where they had 500,000 people from the general population. So these are not people presenting with pain issues. They're general public members. So just to tell you a little bit about them, the average age was 56, but we're talking about the whole adult lifespan, about half male and female, a predominance of white British people, I guess, and minorities as well. So within that large sample, they found that loneliness was very much strongly associated with both acute and chronic pain. So this is just showing that within even a general population, those links are clearly there. And then turning towards the group that you've been talking about with Matthew just before, with the buprenorphine. So this is actually showing a very steep slope of relationship between people's loneliness scores, you can see along the bottom axis there, and the percentage of patients who are taking non-prescribed or above the prescribed opiate pain management medication. So again, you're starting to see these are more recent 2020 sort of papers, but showing this association between the loneliness and the pain, and then the pain management sort of attempts. So what do we do about this? And this is an area that I've become quite interested in the last couple of years. So when you have a look at what people have already tried to do to manage loneliness, there are a number of individualised therapy-like interventions. So this paper is now 2011, so it's going back a little while, but it's meta-analysis of 50 different studies that had some kind of loneliness intervention, and they fell into these 4 broad categories. So there were sort of social skills training programs, ones that would enhance people's social support, ones that would increase outings and social opportunities, and then ones that targeted what are called maladaptive social cognitions. And in fact, when you looked at them in this meta-analysis, the ones that targeted these very individualised things like skill development were pretty ineffective or had very small effect sizes. The most promising amongst them would have been those ones that target maladaptive social cognition. So those are thoughts about, if I go into this social context, I'm unsafe, I feel threatened, people will judge me, I don't trust people, those sorts of cognitions that kind of perpetuate being isolated and lonely. So what myself and my colleagues at the University of Queensland are thinking here is that maybe if a person is lonely, just doing individual intervention and sending them home to work on their thoughts or their skills is not the way to go. That really we need to do an intervention that's very much more embedded within the social context and within the community, ideally. So that brings me to social prescribing, which is a relatively new concept, at least in the Australian health context. It's going gangbusters in the UK and in other areas, but it's still kind of relatively new for us in Australia. I should point out that social prescribing, as its its full model, has 3 key components. So there's the discussion with, say, a doctor or a healthcare provider about what that patient's needs are. There's the referral to a link worker. So that's the step in the middle where they would actually get to know the patient and what their needs and what their interests are, and maybe have several meetings. And then they would find some kind of group program in their local area that's of interest to them, where they will start to develop some kind of social network and support network around a naturally occurring community group. And that can take a lot of time and is very individualised around what that person's interests and needs are. So the link worker needs to be a highly skilled person who has a really good in-depth knowledge of what's available in their local area. So common activities that are running as part of social prescribing programs are things like arts-based groups. So that might be choirs that I've been quite interested in researching, creative writing courses, that sort of thing. Also exercise and gym type classes, adult education classes, a whole range of different things that are in group form. They're not therapy groups. They're not usually run by therapists as such. They're usually run by specialists in those different types of activities. So a key person in all of this is the link worker. So the link worker must have detailed on-the-ground knowledge of what programs are operating at different times and days and how to get to them on public transport. And they will know the facilitators and the organisations that offer those programs so that they can actually vouch for them and they're trustworthy and they have a pre-existing relationship. And they facilitate the client or the patient's access and engagement with that group program. And if it's not a good fit and they're not feeling comfortable there, they will follow up and keep trying with some other sort of solution. So the link worker is providing a kind of a linkage service that's over and above what your average GP or nurse or social worker even can provide in terms of that onboarding and engagement kind of process and following up process. So there's quite a lot of new research coming out, particularly from the UK. So this is from a qualitative study by Wildman and colleagues. I'll just quickly read it through. So many participants had experienced setbacks requiring continued support to overcome problems due to multimorbidity. So thinking about your chronic pain patients who often also have other health problems, maybe depression, maybe they've got some loneliness and maybe some economic, maybe they haven't been able to work lately. So quite a complex kind of case. Features of the link worker social prescribing intervention that were positively appraised by the participants included that highly personalised service to reflect individual goals and priorities and to focus on gradual and holistic change dealing with issues beyond that very medical health model, I guess. So the important role of a strong and supportive relationship with an easily accessible link worker in promoting sustained behaviour change highlights the importance of the link worker continuity. So is it effective? Does it work? We are at the point now where we don't have any RCTs that have that sort of level 1 evidence for social prescribing for loneliness specifically. There are a number of systematic reviews, but there's been no program that I'm aware of that's had, a full randomised control design. I'm leading a project up here in Brisbane that is going to be a non-randomised but a control comparison design, which is the closest that I'm aware of, and we're benchmarking across with a number of other social prescribing schemes around Australia. This group that we're working with at Nottingham in the UK have published a paper just recently that shows there are reductions in loneliness and increases in community belonging amongst 630 patients in an NHS region. Some other people in the UK have found that it improves well-being, perceived levels of health and social connectedness, and reduces anxiety. In some related work, I've been working with some GP researchers up here at the University of Queensland looking at antidepressant deprescribing for people who've been on really long-term antidepressant medication and looking at whether group programs in the community help manage depression. And they certainly do. So we have a systematic review under review at the moment on that. And there's also an indication from individual studies that these sorts of group programs can also reduce chronic pain. So things like exercise programs, music programs. The thing I need to flag there is that those group programs haven't been tested as part of a full social prescribing scheme. So they've just been given as a sort of one aspect of an intervention trial, for instance. But I think you can see where we're going. We're building all these different pieces of a puzzle that together it looks quite promising in terms of a way forward for people in managing their chronic pain. So I'll just leave you with this one. That seems to be that the things we need to take away from this idea are good regular communication between the stakeholders, that's essential. Clear messaging to patients, referrers and group facilitators. So again, just like you were saying, Matthew was saying before, that some patients really take on board the need for buprenorphine, others really don't consider themselves needing something that's an opiate replacement and feel it's quite stigmatised. A similar thing happens if you don't message well about what the point of social prescribing is. You certainly don't want your patient feeling like they've been sent off to a gardening group and they don't really know why they're there. So you need to be really clear about what the point is and how it's going to help them to meet those unmet social needs, which are actually quite important. We don't have a clear funding model yet in Australia, so the different social prescribing services that we're linking up with are all funded differently, some by state government, departments of communities, some by federal government, like PHNs, some through return to work sort of work insurance type services. So it's quite a precarious context at the moment in terms of sustainability and sort of funding options. But there's quite a lot of lobbying and work going on with the Royal College of GPs, Consumers Health Forum and other peak bodies like that. We also don't have strong ethics and guidelines around who is doing the link work, what kind of training and regulation they might require, and also what other sorts of risks and protections would be in place for patients coming into a social prescribing scheme. So a few things that we need to learn from what's happened in the UK, where they're sort of 10 years further on in this process than us. And that is it from me. Thank you.
Thank you very much, Genevieve. I'm just going to barrel on so we can get to our next presenter and then the panel. So our final presenter for the night is Dr. Angela Simpson. Angela is a health psychologist and research fellow at Turning Point. She has over 13 years experience working in the alcohol and other drug field as a clinician, researcher and evaluator. For the last 5 years, she's worked as a clinical setting, delivering psychological interventions to clients with chronic pain. Tonight, she'll be providing an overview of a new social prescribing project being conducted by Turning Point, the OP-ALMA project. This project is actually the thing that got me interested in actually running an event just like tonight. So I felt it would be remiss if I didn't ask OP-ALMA to let you guys know a little bit about their project, because I think it's a really worthwhile one. So I'll hand you over to you, Angela.
Thanks so much, Adrian. I'll just get this happening. Excellent. So hopefully you can see my slides. And I do want to, thank you, Adrian, for inviting me here tonight to represent our project and tell everyone a little bit about this new project being run by Turning Point, which is called Opioid Use and Pain, Addressing Loneliness in Mature Adults. And this project is a social prescribing project, which is specifically targeting loneliness and social isolation in older adults. So people over the age of 65 who are living with chronic pain, which is currently being managed by prescription opioids. So I'm here tonight on behalf of my team, Dr. Shalini Aranagiri and Sally Brown, who is also here in the audience tonight. So thank you again for having us. So following on from Genevieve's presentation, I really don't need to say too much more about social prescribing, other than just to reiterate what Genevieve was talking about in terms of the importance of the link worker in this social prescribing space, in that they are the expert in terms of the services and groups that are available, and have very important function in facilitating patients' connection to those activities and helping overcome any barriers to engaging with services and community groups. So again, I don't need to say too much more about loneliness. Genevieve has presented a lot of information about the importance of tackling loneliness, and particularly in older adults, there is a large proportion of older adults who report feeling lonely, and certainly there are risks to physical health and mental health and well-being from loneliness, which I won't go too much into given our time. So particularly given the COVID restrictions that we are, facing in Melbourne in an ongoing way, this area of addressing loneliness in older adults living with chronic pain is one that we feel is very important and very timely at the moment. And certainly, what we know about meaningful social connection is that this is a key ingredient in terms of improving quality of life, reducing perceived pain, improving mood and reducing anxiety, and improving function. And all of these things are of interest to us in the OP-ALMA project, and we are hoping to be able to achieve positive outcomes in these areas for the people we will be working with. So it is important to note that there are a lot of barriers to addressing loneliness, and there are barriers in terms of the patient, and this might be feeling anxious or experiencing depression. Pain can be a real barrier to becoming engaged in activities, and certainly not having the motivation or confidence or knowledge of how to get connected can be a factor which needs to be addressed. But also from the clinician perspective, there is limited time, knowledge perhaps of what is available to link people into, and certainly maybe not having the capacity or the time to have those conversations, which is where involvement in a social prescribing project can be helpful. So what the evidence does show is that people would be willing to attend a community program or service if their primary care provider referred them, and a large proportion would also be likely to attend an appointment with a community support worker to look at options for programs, again if they were referred by their provider. But there are a lot of barriers in terms of getting people to engage with community programs or groups. Certainly there are some listed on the slide, the cost, the timing of sessions, and really the big obvious one at the moment are social restrictions. So certainly that makes social connection difficult, and even more important given the risks associated with it. So that brings me to a talk specifically about the OP-ALMA project and what we are hoping to achieve with our project. And certainly we've had to rethink how to target social connection in older adults. Our target group that we would like to work with and support are based in the Yarra Ranges. That's what our project has been funded to do. And certainly community programs specifically for older adults at the moment are either on hold or suspended or maintaining contact with members via the telephone. So there's a lot of limitations in terms of the face-to-face support that can be offered at this time. So in response to this, we are moving towards an online social prescribing intervention. And given that we are talking about supporting older adults over the age of 65, it leads us into this area of how to bridge the digital divide. So we are proposing to support a small group of adults to learn how to use a tablet, which we will loan to them for the duration of our intervention, which is approximately a 4-month period. We'll provide internet connections and technical support to learn how to use the device. And then we will assist older people to become connected to online social supports. So that's one way of overcoming the difficulties with social connection that we're facing currently. The time is kind of right for this type of intervention, given that a lot of community groups and organisations are now thinking about how to deliver their service in different modalities. So people are thinking about how to offer online activities for older adults. So our project is looking at doing a comprehensive social mapping assessment of older adults and asset mapping, which means we want to know who the important people are in an individual's life, and we want to know what activities and groups they're already involved in so that we can understand how we can support them to become involved in other activities. And part of this assessment will also involve a comprehensive investigation of what would they like to become involved in and what are the barriers that are stopping them from doing that. And once we have that information, we will engage our project link worker to support and work with the older person to connect them with meaningful online social connections. And throughout this process, we would also be engaged with the health practitioner in terms of adopting a collaborative approach. So we're kind of all working towards the same goal of assisting the patient to make meaningful social connections. The contact with the link worker we are proposing is that they will stay in touch with the older adults via Zoom, which provides another opportunity to help older adults to build their confidence in using technology in a way that is probably going to be vital for connections to other online social groups, whether that's pain peer support groups or exercise groups or anything else that is considered appropriate for the older adult. And we will also be looking to develop a resource directory of online activities for older adults with pain, which could be a resource which could be disseminated and useful more broadly. Because certainly when we start talking about online social connections, it opens up a broader range of possibilities for connection, which isn't just based in the Yarra Ranges or a particular geographic location. So it's something that we're quite excited about. And as I said before, more and more groups are moving into this online space, which means the pool of opportunities for connection is also going to grow, which is very, very hopeful. So I've really raced through a lot of information about the project, and I may have, left a few things out. But one thing that we are wanting people to know about is that we are recruiting at the moment for this project. And as I mentioned, we are hoping to get in touch with practitioners who can refer at least one patient who they currently see, who's over the age of 65, is living with chronic pain and currently taking opioid medication, living in the Yarra Ranges Shire. What we're proposing to do is to provide the patient with a tablet and help to get connected online, and the tablet will be theirs to borrow for up to 4 months for the duration of the project. And then they will have individual one-on-one support to connect with meaningful groups. As a practitioner, you would be provided with one-on-one coaching to support your patient's online social connections, and also access to pain management resources that we are developing, especially for older adults. So if this is sounding like something that you would be interested in learning more about or getting some more information, we would ask you to please feel free now to share your email address in the chat box for all panelists, and we can follow you up with an email. Or alternatively, you could use our project email address, which is alma@easternhealth.org.au, to send us your email and connect with us, and we can provide you with some more information about this opportunity. So I think I've covered everything, and that's me done, Adrian.
Fantastic. Thank you so much, Angela. So that actually brings us to the end of all of our panelists' presentations, our presentations. If I could ask the panelists to turn on their videos again, if you wouldn't mind. And so we can just ask a few questions. Before we even do that though, I'm going to try something here. Woo! Yeah! Yeah. Anyone hearing that from outside just probably thinks I'm a crazy person, but I hope that communicates the joy.
That was your crowd going wild.
That was the crowd going bananas, exactly. So thank you very much. I can play a bit more if you want. We can do that. We'll do that at the end. I would like to invite anyone who has any questions for the panelists to put drop any questions in the Q&A panel. There was a question that was asked. Oh gosh, there are a few more here. Oh, some of these have been answered already. Oh, that's quite good. Oh, that's excellent. Okay, grand. Some of these questions have been answered. But I would like, if anyone else has any other questions, they can drop them in the panel right now. Otherwise, I have a couple of questions, or if anyone on the panel has a question for anybody else on the panel, it's probably.
I might, because I answered one and that made the question hide, and I might put this more to Matt. Just share the challenges with diagnosis and identification of a opioid overuse issue when the person may or may not have persistent pain. And the person asking the question was, well, how do we work out if they've got real pain or if they have an overuse issue? And what's the challenges there in diagnosis around that?
So I think it's probably the wrong question. One of the things about pain, I'm not a pain physician. Look, I'm new to the whole field of pain, compared to some people. If somebody's, my view is, if somebody says they've got pain, they've got pain. And one of the things that we teach people is that, look, obviously if you come in and your leg's been chained sawed off, there's obvious reason that you may have pain. But in the persisting pain group, it's often people come in with imaging films, and say, check, look at this, I have to be in excruciating agony. And I believe, and I think this is the commonly held view, is that the imaging is not particularly useful, and it's really about how people describe pain affecting their function and how it affects them, and pretty much if somebody, unless I go out with my telephoto lens and film them like the insurance companies used to do, or current affair does, pushing a wheelbarrow up a hill. If they say they've got very severe back pain, that's where it starts. I believe they've had it for years, and they've got persisting pain. I think I don't know if it's part of the question. I think it is a challenge for me, and I don't know if I can answer it easily. It's difficult determining where problematic opioid use in this group starts. So somebody comes in who's using heroin and is in all sorts of difficulty. The discussion about whether they've got problems affecting their life with heroin injection, for example, is not an issue. But people with persisting pain, I think who are on pharmaceutical opioids, when the decision of when it's aberrant or dependence or addiction or whatever you want to call it, that's a very hard one. That's a really hard call, and I think we all find that difficult, particularly when the individual is telling us, my only problem is not enough drugs. It's not, that I'm overusing pain drugs. It's that I don't have well-managed pain and I just need more opioid. So that's a diagnostic challenge, I think. But I think a lot of people do end up in EDs and get told their pain's bullshit and they don't really have pain. And I don't think that's productive. So I just say, if you say you've got pain, you've got pain.
Thanks, Matthew. Anne-Marie, working as a GP,
yeah.
I mean, you would come across this sort of issue as well, I assume. I mean, what do you do? Like, how do you approach this sort of differentiation in this sort of case?
I think some of it is, I agree with Matthew saying when they've got pain, they're feeling pain. Then the key is how are they managing it? And, in terms of aberrant behaviour, if people are using more and more and more and they're just continuing to go up and up and up, their use of medications out of control, to me that suggests it's more than just pain going on here, something else is going on. And there can be some warning signs that somebody is at risk of developing an addiction, potentially something simple as smoking, that's an addiction and so on. There's already some addiction circuitry set up. But other coping skills, how do they psychologically manage it? Yeah, but they overlap. Yeah.
I suppose it really hammers home the importance of, trying to continue to conceptualize pain in terms of the biopsychosocial model, because it all really ties in all together at the end of the day, both the potential for dependence as it weighs up against, the existing chronic pain and the other things that could be contributing to either.
Yeah, you need to take that approach. Yeah.
Fantastic. Well, look, we've hit 9 o'clock, everyone. So I think, no, hang on a tick. My little trick isn't working. One sec. I was pressing spacebar to be able to speak it. If you take your finger off it, you go mute again. Got to remember that. So look, I just want to thank all of the presenters for their time tonight and the amazing information they provided to our audience. I'm just going to do this again. Oh, there we go. Wonderful. Yes, not very professional, but there you go.